Hello, Trupti ma'am.
Yeah, please tell me.
Yeah, ma'am, you have joined. I was calling you actually, ma'am.
Yeah, please. What is it? I'm unable. Oh,
It's
it's
okay.
sound.
Okay, ma'am.
My
Okay,
phone
ma'am.
isn't.
Yes, yes, ma'am. In a short time, we will start.
Oh, hello. Namaste.
Hello. Hello. You can hear me, ma'am? Hello.
Yes, we can. We can. Yeah.
Good morning, everyone. I, Mr. Amar Tomer, extend a warm welcome on behalf of the principal, CEO, and management of Patkar-Varde College for one-day RUSA-sponsored national webinar Biofacet on genetic counseling, organized by the Department of Microbiology and Biotechnology. I also welcome our guest speakers of the day, Dr. Trupti Patel and Ms. Adrija Mishra. Encouragement, enthusiasm, excellency are the major aspects of our institution, and with a similar objective of encouraging the spirit of research and innovations, Patkar-Varde College feels proud to host this national level webinar. Chikitsak Samooh's Patkar-Varde College was established in 1964 in Mumbai's western suburbs. Since its establishment, it has constantly worked towards students and society welfare by bettering its infrastructure. Our college is an autonomous college affiliated to University of Mumbai and has been re-accredited with A plus grade by NAC third cycle with an institutional score of 3.53. We have also received Best College Award in 2016-17 from University of Mumbai and are also a DBT Star College awardee. We have also obtained ISO 9001-2015 certification. The college has grown steadily over the last 5 decades, and in keeping with the spirit of learning and growing through criticism, we have set high standards working continuously towards advanced goals. Our college offers a wide range of undergraduate, postgraduate, and PhD programs. In addition to the traditional programs, the college also offers the emerging need-based programs like BSc in Biotechnology, Microbiology, Aviation, Computer Science, and Information Technology. BMS, BCom Banking and Insurance, BCom Accounting and Finance, MCom Advanced Accountancy, MCom Banking and Finance, and MCom Business Management. Our students have consistently bagged top positions at university and board examinations. Now, I would like to introduce our respected principal ma'am, Dr. Pratibha Gaikwad, an academic and administrative leader, author, resource person in MA Economics from Wadia College, Pune, and PhD from Pune University. She has 27 years of teaching experience. As a PhD research guide, ma'am has guided 12 students and 4 students are pursuing PhD under her. She has also been conferred two design patents by Government of India. In the capacity of NAC peer team member, she has assessed 40 plus colleges throughout India. Now I request ma'am to address the participants.
Thank you, madam. Very good morning, almost noon to one and all. I welcome you all on the very fruitful academic activity occasion organized by Chikitsak Samuha's Patkar-Varde College's Department of Microbiology and Biotechnology, RUSA sponsored one-day national webinar on Biofacet's 2023 genetic counseling. Indeed, it is a very important and upcoming topic in these days. I take pleasure in inviting two very enlightened speakers, the chief guest of today's function, Honorable Dr. Trupti Patel and Honorable Adrija Mishra, who will be enlightening us with their valuable views on genetic counseling. As rightly stated in the introduction, this college, especially this samstha, has a long tradition of 117 years in the field of education, and as a principal of this college, a premier educational institution in Mumbai's western suburbs, will soon be entering its 60th year of establishment. Since its establishment in the year 1964, we have constantly worked at increasing the number of programs, which are now at present 50, which are catering to the academic needs of around 10,500 students. The college has grown steadily over the last 5 decades. And in keeping with the spirit of learning and growing through introspection and interaction, we have set high standards working continuously towards advanced goals. All this has been possible due to the proactive steps taken by the management. Find it very essential to place on record my high level of appreciation and gratitude towards the president of Chikitsak Samuha, Honorable Mr. Rangnekar Sahib, the Joint Secretary, Honorable Dr. Gurunath Pandit, our all the time available, very proactive, energetic, and positive minded CEO, Honorable Dr. Mala Kharkar Madam. I also appreciate the efforts put in for this particular conference by Professor Mrs. Dalvi and her team. It is a matter of great hard work one has to put in to organize such type of academic activities. So I place on record my high level of appreciation to Mrs. Dalvi and her teaching as well as administrative staff for organizing this very wonderful and fruitful event. Now, genetic counseling, which is a word which is very new to me as well, because I am a student of economics. I hardly know anything about genetic counseling, due to which this particular activity will add to the knowledge of many like me who are participating in this particular conference. The purpose of genetic counseling, as I learned, is to increase families' awareness and understanding of particular genetic disease and the risk and benefits of testing, disease management, and the options available to them. So I consider it as a proactive. Prevention is better than cure. So genetic counseling will work according to the phrase prevention is better than cure, and that will give good health as well as psychological confidence to many who might be facing this type of situation. Genetic counseling also allows the affected individuals or their family to develop the psychological tools required to cope with the consequences of genetic disorder. Means when a person is well informed about what would happen, he will not be taken by surprise, and he will not have that psychological shock which leads into a trauma which exists for a very long period of time. So something like genetic counseling is like a need of our after the corona pandemic. We all have faced tremendous physiological as well as psychological, and along with it comes economic, sociological, and various other challenges. So this conference will indeed prove to be of immense help to all the audience. It will add to the existing branch of knowledge. And with these words, I once again take the privilege of welcoming Trupti Madam and Mishra Madam to this conference. And I wish you all a very meaningful and fruitful day. Thank you. Jai Hind, Jai Maharashtra.
Thank you so much, ma'am. Now, I'll give a brief introduction of our department. Department of Microbiology and Biotechnology organizes Biofacet every year. Started in the academic year 2012-2013, Biofacet is a stride taken by our department to provide a platform to scholars, teachers, and experts from various fields of science and technology for academic interactions, elevation, and enrichment. It has also taken initiatives in helping students in extending their minds to diverse fields that are available in biological sciences. We have been organizing Biofacet every year at national and international level on varied topics like plant health management, biosimilars, vaccine development process, CRISPR gene editing in virus research, and advances in plant research. This year, we are organizing Biofacet on genetic counseling, and the purpose of genetic counseling is to increase families' awareness and understanding of specific genetic diseases and the risks and benefits of genetic testing, disease management, and the options that are available to people to provide a sense of relief from uncertainty and help people manage their health care. Arranging such webinars would not have been possible without your support and participation. Thank you very much, dear participants. We are sure that this webinar would certainly complement to your learning objectives. On this note, we begin the first session of the day with Dr. Trupti Patel, Professor, School of Biosciences and Technology, Vellore, Tamil Nadu. Her research areas focuses on cancer genetics, cytogenetics, and toxicology. She has 5 national and 35 international publications to her credit. Ma'am has also authored 5 books and 4 students have completed PhD under her guidance. Ma'am expertises in cancer biology, cytogenetics, molecular biology, in vivo and in vitro toxicology, and biochemistry. Ma'am is here to share her knowledge on importance of prenatal genetic testing. Ma'am, it is indeed our pleasure to have you with us today. Now, before we begin with the webinar, I request all the participants to switch off their cameras and speakers so as to allow smooth conductance of the webinar. If any technical problem arises during the webinar, we will try to resolve them. Kindly post your questions in the chat box. It will be answered at the end of the session. Now, I request ma'am to address the webinar. Thank you.
Thank you. Thank you very much. Should I share my
Yes,
presentation?
ma'am.
Hello, Trupti ma'am.
Yeah, speaking.
Ma'am, yes ma'am. You can share your screen with your presentation.
Yeah, I am trying to do that. I was able to look at the presentation before I started. I'm not able to see my presentation right now. My screen is
Oh,
not showing up. It was initially visible and I tried and it shared
ma'am, is
also.
your
But
presentation open
currently,
in PowerPoint?
yes, yes, it
Ma'am,
is open
kindly
on the
go to the
PowerPoint.
share screen option.
Okay, shares. Sure.
Present
So I
now.
have gone to
There
the.
is one box and then that arrow is there.
I have done that.
Okay.
Correct. And that. The only thing it's saying share windows, Chrome tab, share window. And in the window, I'm not able to see my presentation, which I was able to.
Ma'am,
So
acha.
something.
Ma'am, can you just mail us your presentation? We'll share
I
from
can
our
do
end.
that. Okay, you want to do that? I can right away make a, can send you. Okay.
Sorry
But
ma'am,
I
I
think
didn't.
it was, yeah, it was visible just few minutes back. Just few
Yes
minutes
ma'am,
back
it
it was
was. It
visible.
was.
So, I don't know.
Ma'am,
Okay.
if possible, you can mail that to us.
Yeah, I am doing that. I am doing that.
Ma'am. Shall I give my mail ID?
I have Ruchita
Ma'am,
madam's
Yes,
mail
yes.
ID.
ma'am, you can share with us in our mail.
This, I think it was very much visible, so I'm kind of a little. Okay. So it is in your inbox, if I'm not mistaken. Um, Probably 2 mails would be in your inbox. So don't worry, anyone is fine with it. Um, at the outset, I would like to thank everyone who was involved in, bringing this together. The patrons are at Patkar-Varde College, the chief education officer, and the principal. Thank you so much for inviting me. Um, I'm also thankful and profusely thankful to the coordinator and the co-coordinator, Dr. Ruchita and Dr. Anupama for inviting me on this occasion for the Biofacet 2023 genetic counseling. Now, the title of my talk is Importance of Prenatal Genetic Testing, and we should begin in a while. I would like to say that this opportunity helps a lot of students to understand what fields to go about once they have completed
Hello,
a
Trupti ma'am.
particular sciences. Yes, please tell me.
Ma'am, your presentation is not visible to us.
I have sent it to you by email.
Okay, okay,
You,
ma'am. Okay, ma'am.
you
We'll
may,
just check it. Yes, ma'am.
yeah, you may share the screen, please. You may share the screen. I suppose I can share the screen. Can you please see? Tell me you can see my presentation, everybody?
Doctor, it's visible.
Yes, ma'am.
Adrija here.
Thank you so much. Yeah, thank you, thank you.
Yes, ma'am, it is visible.
And I'm sure that it is full screen
Yes,
by now.
yes,
Okay.
ma'am.
Yeah. So let us just jump into the presentation. We don't want to delay. Thank you everyone for making this possible for me. So the outline of this talk would be, we'll start with understanding prenatal testing and some recommendations as given by the American OBGY, associations. And then we'll talk about various screening tests that are being conducted in the first and the second trimester, and of course, their indications why they need to be done. Thirdly, I would also like to touch base on the different types of invasive, non-invasive techniques of diagnostics. I would also want to continue and just about touch about talk about a little prenatal diagnosis or genetics and genetic counseling. I'm just going to give a heads up because there's going to be an extensive genetic counseling lecture following my lecture by Dr. Mishra. Finally, of course, I would like to talk about some career opportunities in life sciences if you want to do your PhDs or you don't want to. So, what is prenatal testing or diagnostics? It's a procedure that is used to make sure that the fetus or the baby that's going to come is going to be healthy, and it should not have any birth defects. The prenatal testing is it consists of diagnostics and screening. First, we go through the screening, and then we confirm those results of the screening through diagnostics, and it's both a package, an important part of prenatal care, so that if there is any anomaly or abnormality or malformation in the fetus, it could be detected as early as possible, and the disease burden in the family, in the society, can be decreased. So. What kind of abnormalities we are talking about? The fetus may have an anatomic or physiologic problem that that the growing embryo will show up in the mother's womb, and we test it by different different tests. Usually, this particular anatomic or physiologic changes could be seen in pre-implantation or in IVF, in vitro fertilization and implantation, implanted embryos. While when you talk about genetic anomalies, we are talking about a natural pregnancy and the testing of that. So screening is easy, it is reliable method, but it's not always that the screening works. So we have to confirm everything that comes out of screening. If there is any contradictory finding, if there is a confusing result, the best thing would be to go for 100% diagnostic techniques. So who needs to be tested? Of course, any mother who wants to go for prenatal testing can do so. There is no, inhibition that a young mother cannot go. But any female who is older than 35, it's compulsory for going for prenatal testing. It is also important that they do the initial screening in the first 3 months of pregnancy, first trimester, and then go for the second trimester, and on and forth till they are assured that the baby is normal. Now, there are other reasons also. Sometimes the parent would already have an abnormal or not so normal genetically defective. child earlier, or maybe multiple abortions would have occurred for a couple. A couple who has got some carrier disease, they're carrying some kind of recessive condition, and they don't want to make it a dominant condition in the child, then definitely they will go for a carrier couple will go for genetic testing, abnormal ultrasounds, the initial screening methods, which I'll explain you in a while. Whenever there is abnormal ultrasound or any kind of screening technique, screening test that is not confirmative or is not, it's confusing, contradictory, or maybe, let's hope not, but sometimes it's positive, then there is always, multiple extra tests involved. If a parent has had a addiction problem, or if any of the parent has gone through treatments of cancer, then of course, whenever they conceive, they have to the mother has to undergo multiple tests or the screening test. Uh, if there are any conflicting results, as I told you, then it is best to go through multiple tests. And there is this strange occurring that happens in the parents. It is called as balanced or Robertsonian translocation. Now, here the chromosomes, two chromosomes get a part of each get translocated on the other. It is a balanced translocation, which means none of the genes will be missing. So the protein products will be produced properly in the parent. But when the parent's gonads will produce a oocyte or a sperm, that would be defective. So there is a possibility of the child having aneuploidy because, or the oocyte or the sperm having abnormal chromosome count or non-distension, which can then further go into the fetus. So in such cases, it is best to undergo screening. So any couple who desires to do a screening test, it is always welcomed. And of course, they can also, if they have any doubts, first they go to the counselor, and then usually the young couples go to the counselor, they talk about it, and then go for the testing. So as you see in this particular graph, and it's very interesting, you see that in the age of 45, usually the oocytes will have aneuploidy, and there's 90% of the chance for a fetus to have aneuploidy or abnormal chromosome count or some kind of structural anomalies. The fetus may be abnormal. But at the early age of around 25, the percentage of or 28 to 29, the percentage of abnormality, having an abnormal child is hardly 25. That is a baseline. Any pregnancy can have some minimum risk, as I tell you. There's always some minimum risk in every pregnancy. This calculated risk could be 0.5% of chance of having a numeric or structural chromosome abnormality, 1% of a single gene disorder or polygenic disorder, fetus having minor or major malformations due to submicroscopic chromosomal anomaly. Sometimes, there is recurrent abortion. Parents have recurrent abortion, and in the first trimester, the baby. The fetus is not developed after first trimester, and the abortion occurs. Now, this is in cases where, as I told you, if the parent has some kind of anomaly, then by nature is very kind to us sometimes, like it or not. If the child is abnormal, usually in the first 3 months, the child is aborted, the fetus is aborted, and so there is the disease burden across the family and the society is reduced. Now you see here in this particular slide the percentage of trisomy 21, how drastically it is, it increases with the age of the mother. So if the mother is less than 35 years, the trisomy, the chances of a Down syndrome is 1 in almost 591. But if the mother's age increases beyond 35 and 35 to 45, the chances of a mother having a Down syndrome is 1 in 100. That's 1%. So trisomy 18 and trisomy 13, we don't talk much about, because usually in the first 3 months abortion occurs in such cases. But trisomy 21, usually goes up to the full term, and that's why the screening and diagnostic tests are very, very important. So, how to ensure that the fetus that's developing is safe, it's normal, everything is fine and okay. So, there are certain carrier screening tests. First of all, if the father or the mother knows that they are carriers to sickle cell or beta thalassemia or cystic fibrosis, that muscular dystrophies, then there are specific mutational screening tests. The parent goes through this test and knows that, of course, if there is they are the carriers, then every time they conceive or plan a pregnancy, the fetus has to be tested for the same. Now, the general screening test even if it is a normal pregnancy, there are certain tests like, they go for checking through ultrasonography, etc. And they also check sometimes for in the maternal serum itself. They will check for whether there are abnormal content of certain markers, and that is how they will know whether the child is normal or the screen test is positive or not. And then there are the diagnostic tests that are like confirmatory tests. They could be invasive as well as non-invasive. Invasive is where they retrieve some material from the womb of the mother or from the fetus or from the placenta. And non-invasive is where they do not have to, retrieve a fetal material, can use the mother's blood for the purpose of, testing. So, just a quick, eye on what different kind of recommendations are given by American College of Medical Genetics, ACMG. And I should tell you that there are the Korean, recommendations. There are European recommendations, and then there are the Chinese have their own recommendation policies. India has its own policy. We match more with the American College of Medical Genetics and their recommendations. So I'm giving you just a little of that view. So the screening should be, the prenatal screening should be optional. It should be given to every woman who wants it. If the female age is higher, then definitely they should check themselves for for any kind of abnormality in the fetus. That does not mean that they should go every test. If they feel that they don't want to, then they should have an option for that. The first trimestral screening tests are, multiple different tests, but 3 of them are very, very important, and I'll talk more about those in the coming slides. Of course, there is something called as nasal bone assessment. Again, it is done through, ultrasound, etc. And here this particular test is optional. But if they find that the screening test has shown some kind of anomaly, then they would recommend this particular test. And then there is the there are second trimester. That is when the female enters into the the 4th, 5th, and 6th month of pregnancy. Then there are specific policies to that also. There is triple screening test, and there is the cord test, etc. Finally, the counselor will usually inform the mother about the risk of Down syndrome, or if there is any kind of anomaly found. They will discuss about the pros and the cons, and the decision is always left up to the mother and the father or the family. Okay, if there are multiple pregnancies, again there are certain tests that are required. It happens again in vitro fertilization, where multiple embryos are implanted, and there could be a chance of multiple pregnancy. The knuckle transclusency test, the NT's test, is basically looking for any abnormality, and if this test is found to have a measurement beyond 3.5, then definitely they recommend to go for a new test, because there is a chances of aneuploidy like Down syndrome, or adverse syndrome or Patkar syndrome, or anatomically the heart would not be properly working, etc., or properly developed, etc. Then there are the amniocentesis, the chorionic villus test, and a maternal serum alpha protein test, which are also used. Finally, it would be all up to the mother which test they want to go through and how. If there is anomaly, they will of course recommend more tests. The tests that are or the screening or the diagnostic tests, whichever are done, should have 100% reliability, maintain the quality of the test by the laboratory. So you have to go to a standard laboratory so that there is no wrong or misinterpretation of the reports. Now, the first trimester screening, which is done almost at the end of the third month and the beginning of the fourth month, between the 11th and the 14th week, usually to find out whether the fetus has, if at all, to detect, early detection of trisomy 21, Edwards, Patel syndrome, etc. This screening test would usually include the blood test. We take the maternal blood, and from the serum we do the marker study of human chorionic gonadotrophin and pregnancy associated plasma protein A, PAPPA. Again, there is an ultrasound scanning done to check the space between there's some clear space between the back of the neck and in the fetus. It is called as the knuckle translucent test, and in this test, if there is any anomaly, then they will also do the pelvic and the nasal bone scan for the fetus through ultrasound. So traditionally, first trimester would have maternal serum beta HCG or free HCG. Nowadays, the people don't go for total HCG; they go for a free beta HCG, which is more accurate test. And then there is the PAPPA, and then there is the fetal ultrasonography that goes through. Now, when the first trimester test can be also followed up or combined with the second trimester, and that would be triple screening test or quadruple test, also called as the MSS4, that is maternal serum screening 4. All of this is to ensure that the growing baby is having a normal growth, is normal, and has no problem within its anatomic, in its physiology, or in its genetics. Okay, so this is just a understanding chart of how the biochemical markers are combined with the maternal age history. They take the history of the mother, they take the ethnicity of the mother into consideration, whether mother has a diabetes, whether the pregnancy is IVF or natural, and then they will go for certain ultrasound markers also, and finally they will assess the combined risk, whether the child will be normal or may have some kind of chromosomal a numeric or usually a numeric abnormality. Sometimes also they will presume that there is a structural anomaly, but it has to be confirmed by a diagnostic test. Now, ultrasound is a non-invasive prenatal test, and it is used. The knuckle translucency test is done between the 11th and the 14th week. What happens here is you see this picture. Interestingly, when it is normal, you see that the measurement, and the American Association has given that for after 3.5 of this distance. If it is greater than that, definitely the mother should undergo more diagnostic and more screening tests, because then there is a much higher risk of aneuploidy, like in this case you see. But if it is less, 2.99 or something, then of course the pregnancy may be normal and the fetus is growing normal, and that there is no chance of trisomy, usually trisomy 21. As I told you before, 18 and 13 are usually aborted in the first trimester. So here again, you see there is an interesting picture of the normal versus the the higher distance of the knuckle translucency. As I told you, the detection rate usually with this particular test is 70%. That is, out of 100 cases, 70 times it will accurately give you the right result. Sometimes, and because they are screening tests and non-invasive in nature, there is a possibility that there could be a false positive and a false negative. Most of the time, it is false positive, alarming the people that the baby may be abnormal and we should go for more tests. So that is okay. Like, there are follow-up tests and we can do that, but we don't want to, in any case, while doing the diagnostic test, damage the fetus. Okay, so here there is the basic ultrasonography. As I told you, it confirms the actual gestational age, it confirms the fetal viability, it detects multiple pregnancies. If there is in the second and third trimester, that is at the final end of the pregnancy, it also says if there is any skull anomaly or the spine anomaly, heart is normal, bladder, kidney is working properly, stomach or abdominal wall is proper, and the baby is receiving proper blood from the mother and nutrients from the mother. Targeted ultrasonography is done for the couples with who already have known congenital malformation in the family. That is, a sister's daughter or a son, or a brother's daughter or son, or a sibling who is now abnormal, or maybe they have had an early child who is abnormal. In such cases, of course, the targeted ultrasonography is done for congenital heart diseases to check whether the heart of the newly formed fetus is normal, or the cleft palate and the lip, that is, certain structural anomalies of the upper lip, etc. And if there is an abnormal serum marker in the first 3 months, then they would also follow up with the targeted ultrasonography. Now there is this high resolution sonography to see if the baby in the gestational age, if it is of 3 months or 4 months, but it is not showing the growth, okay, or the amount of the amniotic fluid surrounding it is not proper, then of course there could be multiple more anomalies like the renal malformation or the lethal form of skeletal abnormalities, or the arm is not developing completely or the leg is not developing completely. There is gut, the foot pipe is not developing, gut abstraction is there, microcephaly, the head or the skull is very small, hydrocephalus, where the head, the skull has got water content in it and that's why it is bloated. This kind of fetal anomalies can be detected by high resolution ultrasonography. Now, the major serum markers in the first 3 months of the pregnancy are, as I told you, PPA, which is also produced by the placenta, and basically they take the blood of the mother, and in the serum they will look for this. But it is a biochemical test, and it indicates whether there is a particular aneuploidy or a Down syndrome baby growing. Again, human chorionic gonadotropin (HCG) is again, it is produced during the pregnancy by the cyto, I'm so sorry, trophoblastic cells of the placenta, and they stimulate the corpus luteum to produce progesterone, which is required during and post pregnancy, mainly after parturition. So again, the indications for this particular serum marker is to see whether the child would be normal or unemployed. Here you see a particular, very interesting article by Luca in 2014. I know it's an old paper, but somehow it does give you a very correct estimation or the correlation between the PAPPA and FCG in the first 3 months of or first trimester of pregnancy. You see in the control, this is totally, fine. It is concomitantly increasing, that is simultaneously increasing as the pregnancy goes forward. But as you see in the trisomy 2118 and trisomy 13, the SCG secretion is decreased significantly. Okay, and as you see in the trisomy in 18 it is decreased significantly, and to some extent in 21, but not much affected in 13, as you see. And the secretion of the PAPPA, that is this particular line you see, is very low when it comes to all kinds of aneuploidy. So you see that there is a correlation, and that is why such markers are selected through multiple research. So here is the thing: everything that goes into diagnostics, or everything that we understand as a test, that is the doctors advise you to take, goes through rigorous research before it comes into the final outcome to the patients. Okay, so the mother has an option of only going through the first trimester screening. Usually young mothers with low risk, they don't need to go for other screenings, but sometimes they want to. So there are different types of regimes that are followed: sequential regime, integrated regime, or the contingent regime. Contingent is very interesting. So in the first trimester, if a single marker is found normal, then you want to do the follow-up of that only, and you don't want to go and do every test that is required. So interestingly, there are multiple ways in which a mother is given screening test, and advised that the baby should be normal. And all of this is in the final run is to reduce the anxiety or the genetic burden to the parents and to the society by and large. Okay, so this is all for the well-being of the society. So the maternal levels of alpha keto should be done in the second trimester, that is after the third month, between fourth, fifth, and sixth month. Okay, there is also one more optional test available, and this is by large growing as a very interesting protocol nowadays, but still we don't have enough data for it, so there are certain challenges. Other than that, self-free DNA screening protocols, that is, they presume, or they know that the baby's DNA will be floating within the mother's blood. So they take the mother's blood, they isolate, or kind of just get the baby's DNA fragments, do a digital PCR, and go for the testing. Very interesting protocol coming in, and it has really given us a good answer to newer types of techniques. So here is I wanted you to have this table. Look at this table. You see that there are different types of tests: the triple screen, the quad screen. I'm coming to that, and different regimes available. And you see when they are done is of course very important, but the detection rate and the new protocols. I was just talking about the cell-free DNA. It shows 99% of sure shot detection of any kind of disease, including trisomy 21 in the baby. So it's a very interesting protocol coming up. There are multiple tests, and we're talking about all of these tests one by one. So screening both the first and the second trimester. Then the of course the mother will go through the translucency translucent translucency test, PAPPA, the HCG that we were talking about. And then in the second trimester, they will go for alpha fetoprotein, the HCG, or this could be total HCG. And here they will go for free HCG, beta HCG. And then there is the unconjugated estradiol. Now, estradiol is this is a hormone that will be increasing with the age of the gestation or with pregnancy. There is one more test that they do, the dimeric inhibin test inhibin A. Now, if it is not done, then it is called as triple screening, and the accuracy of knowing that the fetus is normal is 70%. Now, when they take up the dimeric inhibin A test, then it is called as the quad screening, also called as MSS4 screening, and that would give us 80% accuracy of the testing. So, well, why not one more test, right? But financially, it has to be. There are some challenges, And there are some NGOs that will help the mother if they are economically backward. So, and then there is the cell-free DNA test, which would be taking a high-cost test, but many can afford it nowadays. So, what is the free beta HCG? I am going to go into a little of molecular science. Adar and Java et al. They found that the beta subunit of the SCG mRNA. So instead of the total mRNA of SCG, if the beta subunit is the only one that is the expression of the protein of that is detected, then it is found to be markedly increased during aneuploidy. So instead of going through the total, which will reduce the sensitivity of the outcome, we can only do the free beta SCG, and in that case, you will see more accurate and more sensitive outcome to the screening test. Again, second is the alpha fetoprotein. It is a particular kind of protein that develops into the liver of the fetus, and it is then floating in the mother's blood. And so from the mother's serum, we can do a biochemical analysis, and you can find out whether the pregnancy is normal or abnormal. That is up to the reading or the outcome or the or what you call as increase or decrease of the AFP, that we will say that the pregnancy is normal or abnormal. So the AFP test is a very important for females older than 35 and who are pregnant and their age is high. Family history of birth defects, again, AFP is alpha fetoprotein is important. A mother who is already having diabetes, not pregnancy related diabetes, but is having, is already a diabetic, then the AFP test is very important. See, you see that the alpha fetoprotein marker not only in the maternal circulation, but it is also found in the amniotic fluid, the fluid that is in which the baby or the fetus is floating. I'll come to that a little later, but then of course that's very important. And this test will detect whether there is any genetic condition like Down syndrome, the incorrect due date, multiple pregnancy, neural tube defect like the spina bifida or encephalopathy can be detected by alpha fetoprotein marker. Then we have the next marker is, I'm so sorry, unconjugated estriol. Now, this is again, I would like to go to a little molecular part. That Koenig et al. They found that there was some correlation between low unconjugated E3 and increased AFP, alpha fetoprotein, and this was linked to trisomy 21. That is that the fetus that the mother is carrying may have trisomy 21 or Down syndrome. Okay. Now the normal levels during pregnancy for E3 is 4 nanomoles nanomoles per liter at early pregnancy, but at later part of the pregnancy it increases. Now, when this particular increase is not seen, and it shows that it is not 100% and just 75% of what is expected value, then there is definitely some kind of anomaly in the fetus. Inhibin A, I said that this has just lately been added, and is again from the placental trophoblastic cells that this particular marker is secreted. It is very important because it is involved in embryonic implantation, proliferation of the association of the cells, that is detecting the anterior side, the posterior, the dorsal, the ventral, the lateral of the growing fetus from the blastomeal stage into the completely grown fetus. So at the full-time term pregnancy, it has to be very high. Okay, it needs to be very high. So inhibin A is one of those markers. And you see that these markers are very important. Low PAPPA in the first trimester and high AFP in the second trimester is associated with adverse pregnancy. Now, lower blood levels of AFP, estriol or E3 with high level of SCG And inhibin A, again, adverse pregnancy. Now, if it is trisomy 18, very interestingly, all the markers that we have been talking about, all the markers will be very low, very low. So from the normal levels, each one will be lower than that it should be. So that in that case, they say, okay, this particular fetus may have trisomy 18. So this is a very the cumulative chart of what I was speaking. Trisomy 18, everything is markedly low. Of course, there is always a chance of sensitivity of the test has to be sometimes we have to go through what you call as the success rate versus the failure rate. Sometimes we have what you call false positive and false negative in such cases. I'm sorry. Bringing about, just to show you some pictures, this is how spina bifida looks like. Microcephalus, hydrocephalus, diaphragmic hernia, and skeletal dysplasia. So just so that you understand how a baby, abnormal growing baby would look like under the ultrasound, or when it is growing abnormal. These are the kind of things that would be present within the baby. Or now, having talked a little about screening test, I would talk something more about diagnostic tests. Now, diagnostic tests could be, non-invasive and invasive test. Do I have some time? How much time do I have? Excuse me. Can I continue? Okay. So there is a non-invasive test and invasive test. Non-invasive, I've just discussed some time back. The ultrasound examination, the MRI. MRI is usually when in the first 3 months the baby has been found to be slightly abnormal, or we have not got a good test result, then MRI is done. Echocardiogram, if they find that the baby's heartbeats have not been normalized over the first 3 months, then they want to go for echocardiogram. So these are not invasive tests, they are non-invasive tests. And then there is the diagnosis of the fetus through through certain tests like the chorionic villus sampling, the amniocentesis, etc. So let me put it right away. The CVS is done at the end of the first 3 months, but not lesser than 10 weeks and not beyond 13 weeks. Amniocentesis is started. We can start looking for the babies or taking the amniotic fluid only after 15th week. Why am I talking about this? Because if this particular guideline is not followed, if they try to do the chorionic villus sampling before 10th week, then there is a chance that the baby becomes abnormal, or there is a miscarriage. Okay, and if they do the amniocentesis before 15 week, such things can happen to a normal baby. So they don't want to do that. So there are specific guidelines to do the invasive test. So one non-invasive test, which is again at the forefront, as I told you, is a cell-free DNA, where metallar plasma consisting of the baby's DNA fragments or the fetal DNA fragments are used. So invasive prenatal test, chorionic villus amniocentesis. Again, there is umbilical cord sampling, cord blood. They take the blood from the umbilical cord, or it's also called as the chondrocentesis, fetal blood sampling. It is also called as the umbilical vein sampling. Nothing but they are taking the blood directly from the baby. Sometimes they have to go invasive and take the blood from the from near the liver or from near the heart. So they have to do that also. So most of this particular tests are again to check whatever we got in the screening test. Is it confirming? This test are confirming is the baby having a Down syndrome, or is it having some genetic problem or not. So Very interesting chart again. It says that if there is invasive prenatal testing, there is chorionic villus or amniocentesis. If the chorionic villus, they have to grow this villi cells, okay, and they do the karyotype. If the karyotype seems normal, but still there is a fetal abnormality or malformation that is found in the ultrasonography, etc., then they will look for the pathology. They will look for the other backup diagnostic methods through which they will find whether there is an abnormality or this particular ultrasound or screening test was wrong. Okay. If there is a pathological karyotype, they will go for more culturing and then the parents will go for genetic counseling. Okay, the couple has to go for counseling. Similarly, in the amniotic fluid, they can do interface fish fluorescent in situ hybridization. I'll show you a picture. If it is normal, then again, because there was an early malformation signal in the screening, they go for another array test. They will find whether it's is it normal or normal. If it is normal, they'll go for counseling. And if it is normal, then again they will have to go for counseling. But then here there will be a little more anxiety in the parents. So and then there is the pathological. If it is found to be pathological, they will confirm it through the culturing. Let us go one by one. So here is how the chorionic villus, they take a small part of placental cell and then they will culture it. And once they have cultured it, they will go for testing. I'll show you the test at the end of the description. So at the 10th week of gestation and up to the 13th week, they can do the chorionic villus sampling. In the chorionic villus sampling, there is only one small drawback. If they take the amniotic fluid, now they can also do the alpha fetoprotein marker in the amniotic fluid. But if they go for just the CVS, then it cannot be done. Again, there is a small chance of contamination. Sometimes there is a placental mosaicism. This is very interesting and challenging for the cytogeneticist because see, if the chromosome number is showing normal and plus then there are certain cells showing abnormal number of chromosomes, then we don't know what to give to the as a diagnostic report. This in the placenta there are certain types of mosaicism, that is there are cells which could have different number of chromosomes, but this does not 100% indicate that the growing baby has abnormal chromosomes. This mosaicism could be just restricted to the placenta. Now this is very important. We will have to do more tests just to rule out this thing. Okay, so there is some underlying risk of limb deformity or miscarriage if you go and do the test outside the guidelines. Amniocentesis, retrieval of the amniotic fluid and culturing the cells, and then of course doing the same test that we do with the CBS. Again, in the amniotic fluid, we can do two more marker tests, the alpha fetoprotein and the acetylcholine esterase test. This is very important to detect neural tube defect, malformations like, multiple types of malformations, water retention in the baby, etc. Contamination of the sample with the fetal blood. Like if the fetus has some bleeding, internal bleeding, it is not allowed. The baby cannot bleed, right? The fetus is just growing. So it's very important. The elevated alpha fetoprotein in the amniotic fluid. Okay, in the amniotic fluid, we are not talking about the maternal serum now. We're talking about the amniotic fluid. With the presence of acetylcholine esterase, we'll say that virtually 100% there could be encephalopathy or spina bifida. I just showed you a picture. This is encephalopathy and this is spina bifida. So this 100% if acetylcholine esterase is present in the amniotic fluid. Okay, so this is how it is done. Now, I'm not going into the detail of how the test is done. It can be done transabdominally or it can be done transvaginally. Transabdominally is a better and a safe option, and it gives you the results that that everything is fine and hunky-dory if nothing, if there is no cholinesterase, or if the alpha ketone protein marker is as required. Sometimes in the amniotic fluid there is blood. This blood could just be some maternal blood, so we don't have to worry. But if the blood is dark red or brown, if the amniotic fluid is dark red or brown, then there is a risk of miscarriage. So, whenever this particular techniques are employed, they are employed by highly skilled doctors. Highly skilled doctors. Umbilical blood sampling is one of the most dangerous forms. So, perinatologists are trained perinatologists. They will inject the needle through the mother's abdomen into the placenta or near the baby's liver and take the blood. Okay, in some cases also near the heart and the liver. But again, the tests that they do are similar. The diagnosis goes for chromosome anomaly. If the fetus has got anemia, if there is a Rh positive negative factor problem, if the fetus is not having good level of oxygen or is normal oxygen, the fetus is infected, and if the fetus has to be given some kind of medication, for some reason, certain diseases that develop in the fetus, like the toxoplasma, etc., they have to inject certain antibiotics. So sometimes it is done through the umbilical cord. Now, these are the different tests, indicative tests that are done for different kind of techniques. But most of the techniques will require all of the testing done. And I'll just go and jump into the testing part. But before that, again, there is a cell-free DNA testing. Here, nothing has to be done. Take the mother's blood, isolate the fetal's DNA, and from the fetal DNA, you can do chromosomal testing, molecular testing, and high throughput diagnostics. That has become a very important thing in today's world. Okay, so most of the time, this particular non-invasive prenatal cell-free DNA testing has found to be very accurate. Okay, for Down syndrome, it has sensitivity beyond 99%, which is very good. For trisomy 21 and all, of course, there are some little less data, so this the accuracy is little less. Okay, so overall, well, for Down syndrome, this particular test has become one of the hallmarks nowadays. So, what are the different kind of tests that they perform once they have retrieved the sample from the mother's blood or from the from the fetus? They do the chromosomal aberration test. They do the monogenic disease, single gene disease mutation test by PCR methods, HPLC method, and then they do the polygenic or multifactorial disease test. Or also changes that happen in the fetus because of the exogenous factors also can be studied. So here is a fetal karyotype. It is an abnormal karyotype. It has got 3 chromosome 18. You see? So yes, there is adverse syndrome in this baby, but you see here the chromosome 11 shows a small break. Now, once they get this kind of abnormality, they will have to go at least 50 to 100 karyotypes they will do, so that they will rule out that this is just an artifact and this is the real thing. Okay, so this is the real condition, this is just an artifact. Similarly, when they do amniocentesis, they don't even have to culture the cells. What is amniotic fluid? In the fluid, how come the cells? I'll tell you something. So the baby is growing, right? When the baby grows, it sheds its skin cells. It will shed its cells, and in the amniotic fluid, these cells will get accumulated. Okay, so when they retrieve around 10 ml of amniotic fluid, 10 ml is okay. We cannot retrieve very high amount of amniotic fluid. When they retrieve some amniotic fluid and then they centrifuge, you will see that there is a small palette of cells. Now, these cells are some live cells and some dead cells. Okay, the live cells can be cultured. You can grow the cells outside in the medium, and then you can do the karyotype like you just saw, or they can directly take this particular what you call they can do the cell, take the cells, and in the interface cell they can do fluorescent in situ hybridization. So they use specific kind of probe. Here they have used a probe for chromosome 21, and you see that there are three counts. Sometimes, just to make sure that we are doing the technique is right and there is no artifact, they will use two different probes. So this is a probe to just check whether the this particular probe has like the technique has gone smoothly or not. So here 13 is just for normal understanding, 21 trisomy is what we are saying as the abnormal interface cell. Now, there are certain limits to cytogenetics. There could be culture failure. There could be microscopic deletion, or micro deletion, micro duplication that could be missed out. Though we have good fish probes, but still it's a costly business, and sometimes you miss it. And sometimes, as I told you, there will be mosaicism. It could be restricted to the placenta, where the number of chromosomes of different cell is slightly varying. There could be two different cell lines, but it is only in the placenta, and the baby could be normal, or sometimes it could be in the baby also. So this kind of culturing artifacts could give us some kind of causes some kind of limitation for this test. I'll go and tell you what happens if there are certain limitations. And then for the monogenic diseases, like if the person, father or the mother, is a carrier of beta thalassemia, then they will go for HPLC related or TCR related tests. If the mother, there is a mother is a carrier of muscular dystrophy, the abnormal gene in the X chromosome, then there is of course a PCR test to know that whether the baby is going to have it or not. So here is a PCR test for muscular dystrophy. Here is a PCR test for understanding whether the baby is carrying the same abnormality or monogenic defect that the mother is carrying. Okay, mother or the father. So for following the phylosynthesis is nothing but chorionic villi sampling, or the amniocentesis. Cytogenetic analysis is done, which is very good. It is a gold standard. But sometimes, we want to do multiple tests, multiple genes we want to check in one test. Then we go for multiplex PCR assay. What we do is in this test is that we take around 40-50 probes, okay, probes for the what for very specific genes, the genes that we want to understand and see whether the baby has them normal or not. And then we perform the multiplex PCR, and then we will look for diseases like Pynchon's muscular dystrophy, or the short stature homeobox containing gene, which is very important in Turner syndrome. I have found in my career, I have found a female having chromosome XX, a female looking, the person looks like female but has got X and Y. Sometimes there is an overlapping of the autosomal regions in the X and Y region, and that causes some kind of sexual anomalies. And these anomalies can cause Turner syndrome. Of course, you know that there are chromosomal number change. Sometimes the chromosomes are fine, the number is fine, and still the person will not develop as a normal male or a normal female. Now, there is something called as array CGH, a very, very interesting, test, a comparative genomic hybridization test. Here, what they do is that once they go through the cytogenetic test or the karyotype, and they do find that there is something that's different, but we are not able to make out, then what they will do is they will use a reference genome, and they will, they will have the normal genome versus the abnormal genome, and from they, there's a complete, high throughput microarray technique that they follow, and the result output is something like this. So once the result comes, they will be able to check whether there is a micro deletion or a micro duplication happening in some regions that are not detected cytogenetically. So here the karyotype of the baby looks very much normal, doesn't it? Totally normal it looks. But you see, the mother and the father have specific gene microdeletion and duplications, which could then go into the baby. So the fetus may have it anomaly, or the fetus may not grow normally because the parent may be carrying some kind of anomaly. Okay, so Other than that, there is the, as I told you, high throughput diagnosis. High throughput diagnosis is very interesting. And, they take I told you, they isolate the DNA fragments of the baby. They perform the digital PCR, that is on a chip. They perform on a nano chip. Sorry, the chip is slightly larger, but there is a nanopore within it, and in that they perform the PCR. After the PCR, they will, they can do the next gen sequencing, etc., high throughput sequencing, etc., and they find out whether the particular, gene is normal or abnormal. Now, high throughput testing is very, very preferred. It is little costly, but most of the time it is preferred. But it is not without challenges. The biggest challenge is to interpret the outcome. So you have the whole baby's genome in front of you, right? You cannot tell the parents that this is wrong, that is wrong. There could be certain pathogenic variants, and there could be certain normal variants. So it's very important what we should interpret the result as. Okay, so currently there are some challenges because there is not sufficient data. We don't know how the accuracy of chromosome trisomy 13, trisomy 18, or sex chromosome aneuploidies could be interpreted. There could be false positive, which is high occurrence when it comes to high throughput techniques. Micro deletions and micro duplications, okay, yes, they could be detected, but we don't have a sufficient backup data to compare that is it actually a micro deletion or a duplication, or is it just a copy number variation in a specific region which does not have a direct pathogenic effect on the child, or there could not be any disease related. Okay, so there is a lot of ethical you know problems, the ethical problems that arise because of this. And I'm sure that the next speaker is going to talk a lot about genetic counseling and ethics in that. Now, just touching a moment or two about pre-implantation diagnosis, where the couples go for such kind of in vitro fertilization when they know that they have specific anomaly and they don't want to pass it on to the child, so they will use the donor's oocyte or donor's sperm, and they will go for implantation. The blastomere stage of the embryo, up to the blastomere 6 or 8 cell embryo, it is allowed to grow in the medium outside the body. Now, from this blastomere, few of the blastomeres are collected and they are sent for high throughput diagnosis, where they will diagnose that the fetus is completely normal. Sorry, I'm so sorry. The embryo is completely normal. It does not have any. We can predict that it may not have Alzheimer's. It may not have specific type of heritable cancer. It may not have trisomy, etc. And then this particular healthy blastomeres are implanted into the mother's womb, and then they are actually allowed to grow. But here is the problem. In pre-implantation, in the IVF, there is a possibility of multiple pregnancies. Okay, so that's one thing. So what are the 3 forms of testing, pre-implantation testing? One of them is the same, testing for monogenic diseases, testing for aneuploidy, testing for structural rearrangement, all the 3. But now here, it is done on the blastomere, not on the baby cells, not on the mother's from the mother's blood. It is taken from the blastomere. It is done in vitro, and then it is then the implantation of the healthy blastomere is done into the womb. Now, I'm not going to go deep into genetic counseling because we have a speaker to that, but genetic counseling has become a very important part of prenatal diagnosis, because here is the thing. When a couple is going through multiple problems, when they do want to multiple abortions, etc., they become anxious. And when they become anxious, they want to know what's happening in their in the whole process of uh, uh, you know conceiving and giving birth. So, who needs counseling? Of course, multiple people who are female with higher age, family with having genetic disorder, carriers of diseases, consanguineous marriage is very important. marriages among relatives, etc., and people having some kind of addiction and oncologic treatments, uterine infection. If a mother has had multiple infections, then also there is a lot of abortion, and so the mother should go for counseling. And what does a counselor do? They have to do a lot of things. First of all, they have to explain to the family, okay, or to the couple, in a very simple language, what is that they have to do, or what is happening to them, if the fetus is normal or if the fetus is abnormal. What they see, a counselor can never decide for the family or the couple. They can just give their inputs and what is happening with them. And so a lot of things go in discussion of and multiple sessions of counseling are done. The outcome of counseling is whether the parent wants to go for IVF, whether the parents will have a normal pregnancy or should go for termination of pregnancy, and whether the implanted embryos are normal or abnormal. Now, genetic counseling is very important and challenging both in the next generation sequencing era. Why? Because I'll go directly to the problem. The problem is that if I if I am the doctor and I have the whole baby's whole blueprint in front of me, then what should be considered as a pathogenic variant, that is abnormality, and what should be considered as non-pathogenic? We don't know. There are SNPs or polymorphisms that are not going to affect the baby directly. So how do I say what is right to what is wrong, and how what is to be told to the parent and what is to be not told to the parent? Right to know versus right to not know. And then, of course, there is a problem that can come up in the future, and that is CRISPR-Cas editing and developing designer babies. Then there are ethical committees which are going to take a look at that and going to stop it as long as they can. But we don't know whether it's right, wrong. What are we saying? So, of course, there are a lot of recommendations coming from different European nations, American subcontinent, Indian subcontinent has its own, ICMR has its own guidelines, etc. And then finally, yes, you are all biotechnology students, you're all life sciences students of the biosciences. It's your career opportunities. So I find in my class, I find some students are very, very lazy. They cannot do PhD. They are not interested in PhD. Maximum they can go is post graduation, as we call it, master's degree, and that's about it. So after master's, what do you think they can do? What do you think you want to do? So there is MSc in Masters in Healthcare Management. That's something like, you have hospital management, you have healthcare management, you have a lot of things which you can do. So that becomes an MBA, part of MBA, or MSc in healthcare is also possible. Healthcare management, but then most of the time it's MBA. It's a business, a management degree. Then you can go and work with the clinical research organizations, which will, as a clinical analyst, as a clinical trial management. Of course, you have done your BSc, MSc. You have to do a short certification course sometimes. There are lab technicians also who do a short certification course, etc. You can become a genetic counselor after achieving certification of genetic counseling. You can do a forensic law, which is very, very interesting. It is more to do with forensics and with paternity testing, etc., and many more things. Of course, you can do also. You can become a technical writer or a lab manager, where you can you manage the projects, because you already are in the biosciences field. You do write well, then you can help in the writing of what you call proposals, in the writing of manuscripts, and in managing the projects coming into the laboratory. So those are possible. And of course, there is a data management degree, MS in medical data management. It's a very big thing happening right now in the Western countries, which are they're paying great. They're paying more than enough, but here's the thing: there's a lot of secrecy that goes, because you're managing the financial aspects of people who are coming to the hospital, getting admitted to the hospital. So their insurances, etc., and of course their history of their medical history. So that could be a different field altogether. So data management fields are there. And if you pursue PhD, what to say about that? You can become an academician, you can become a researcher, like basic research, go into basic research or translational research by startup grants. You can become a clinical scientist, you can have pharmaceutical jobs in the pharmaceutical companies. And the one I always say is the medical science liaisons. The- These are where in some kind of, let's say, cancer biology, and then you go to the pharmaceutical company, and whatever drug of cancer, anti-cancer drugs that they are bringing about in the pipeline, you have to pitch them in the market for the doctors and tell them what are the indications of this medication, what are the contraindications of this medications, etc. And that is, it is not like medical representatives, that is different. This is medical liaison. They are pitching in the new drugs in the market to the very big hospitals and the doctors. So there is a lot here. If you have any questions, please go ahead and ask.
Hello.
Thank you for this listening to me, first of all. Yeah.
Thank you so much, ma'am, for giving such detailed knowledge on genetic counseling and its diagnosis. And I'm sure that all the participants have got a fair knowledge about this genetic counseling and how it can be carried out, including all the information about who needs to undergo this counseling and to prevent genetic disorders in the near future, and how genetic counselors can help prevent these genetic defects. Now, I would request our participants to post questions in the chat box so that ma'am can pick up those questions one by one and she can answer.
We now move on to the question and answer session.
Yes, participants, you can post
We have the first question.
chat box.
We have the first question. What is the approximate cost for prenatal genetic testing? Does insurance cover the cost of genetic counseling and testing?
As of today, as I understand, the cost will be depending on the type of the test. If it's a low risk screening test, then it is just a few hundred rupees in Indian terms. And if you're looking at high throughput diagnostic tests, then it goes up to like 15,000 to 20,000. And of course, the companies are completely private, so they decide the finances depending on the all the genes that you want to include in those high throughput tests. So for that, it would take around 20,000. But let me tell you, just a half a decade or a decade back, it used to be a lakh, 1 lakh rupee or so. So we are in a place where we are still able to manage the amount. No, as of now, I think the Indian companies, insurance companies, are still not dealing with this part of the high throughput diagnosis, etc. No, they're not dealing. And genetic counseling it's just a very upcoming branch in India. So we do have counselors. Initially, let me tell you, when I was doing cytogenetics somewhere in my 1995 to 2005 or something, we there were no certified counselors. We used to give the report to the patient, and when we give the report to the patient, we'll talk to them, we will give them the future indications, etc. So we were the counselors then. But for now, no, we do have good counselors, and they do give the complete statistics, and they give you a simplified version. And so now it is an upcoming branch in India. So no, we do not have. I think insurance is, to the best of my knowledge, does not cover this kind of testing as well as counseling.
Thank you, ma'am. The next question is, if someone has diagnosed with cancer, how genetic counseling will help him or her to proceed with the treatment?
So cancer in India, we have just started to have genetic counseling. So we don't have subsections But if you go abroad, you'll find that genetic counselor for cancer patients, again, the caregivers, the people who take care of the cancer patient and the patient themselves are given different counseling, because both of them are going through different kind of anxiety and pain. So for that purpose, yes, the counseling is important, and you need to go to the right kind of counselor who can counsel the family or the caregivers differently than the people who actually are going through the condition themselves. That's it.
Okay, ma'am. What are the risk factors in prenatal genetic testing?
In the prenatal genetic testing, as I told you, there is always a baseline, some baseline risk, attached to that. When you are doing the screening test, there is no risk attached. But when you start invasive tests, like the amniocentesis or the chorionic villus sampling or the cord blood retrieval, there is a chance that the fetal may, if the guidelines are not followed or the hens are not trained, there is a chance that the fetus may become abnormal or miscarriage may occur. But very less now that we have good doctors and trained doctors. 0.5, 0.2% is hardly a risk that. But of course, guidelines have to be followed. Otherwise, you have increasing the chance of damaging the fetus or losing the baby.
Okay, ma'am. Thank you so much. There's one more question. How one can be genetic counselor? Is there any specific course for the same?
So yes, VIT is offering a certificate course in counseling, and students do masters in biomedical genetics with counseling. Besides that, there are a few more institutes like Manipal who have started genetic counseling courses. In India, there are very few, and they are upcoming. But abroad, if you have to say, every big hospital or the linked Ivy Leagues, etc., also have genetic counseling. Stanford has it. Johns Hopkins has it. Pittsburgh, all the universities have a separate genetic counseling course. In India, only a few of them. It's just upcoming, and so it's limited.
There is one more question, ma'am.
Right.
How can we convince postgraduate candidates to pursue PhD, where we are in an age of artificial intelligence with an amount of data available online? A supercomputer can do as much as PhDs in fraction of time, whereas students spend years pursuing.
So you can do a PhD in AI and machine learning itself. Why not? So here's the thing: PhD is not something that you can. So if there's so much data out there, what is right? What is wrong? How much data should I filter? If the doctor goes through the data, he or she will think, oh my god, every gene is abnormal. Now what to do? No, something is normal, something is abnormal. Here, as a PhD student, you can develop algorithms, you can develop AI, you can develop a way to ease the plethora of data that's coming out of the machines, or it's coming out of the high throughput technologies. You can actually help in deciphering it, what is right versus what is wrong, what is required versus not required. The doctor should know basically that I have to only pass this much information to the patient. Or if it's just about PhD in any of the sciences, life sciences, then of course there is always something that is still missing out in this world. So please go ahead, and there's a lot to do in the PhD. If you start thinking about it, I still feel, why not a second PhD? So that's what I would say to you. There's so much out there to decipher, to understand, that you should. It's not about convincing. It's about how agile you are, how passionate you are, and how less lazy you are about working. Then you are out there and you can do something new for the people and bring about more data to the people. Yeah.
Ma'am, next question is, what percentage
Sure.
of population in India actually undergoes prenatal testing and are aware about it?
With the first part of the screening, even the low risk mother, as soon as they, in India nowadays, I'm telling you, at this particular level, it's compulsory. So the first three tests that I told you, the alpha fetoprotein they go through in the second this thing. Sonography they do as soon as the mother knows that the baby's she has conceived. They will go for a sonography. They go for alpha fetoprotein test. They go for HCG test. They go for PPAP a test, because these tests are just screening. They just cost some few hundred rupees. Even the lowest of the lowest economic strata can manage to pay that much. And there are certain clinics which give NGOs that are giving such free help to the females. So I would say much higher percentage, high above 90 and 95%, go through the first part of the screening. After that, of course, there is as the money involvement increases, then only specific part of the society or the strata of the society go for.
Ma'am, next question is, if an individual has been affected by diabetes or has a history of diabetes in family, then what is the frequency of diabetes that might occur in generation?
Diabetes has now been, it is claimed to be a inherited condition. So yes, it is possible, but of course the onset of the diabetes can be delayed by lifestyle changes. That is for sure. Okay, so of course you may get diabetes at a later stage. We're not talking about prenatal here, we're just talking about generation of diabetes. Yes, you may get diabetes at a later stage of your life, but if a parent has got it at 50 or 55, then how to delay it to 57, 58, or 60 is a lifestyle thing. So yes, lifestyle helps us to fine tune the onset of diabetes, which can be delayed. And sometimes it's possible, sometimes the diabetes has been shown to skip generation. So there are possibilities of that too, but very rarely.
How do doctors decide if an individual has to undergo carrier screening?
Carrier screening, most of the time it so happens that, see, the mother is consistently anemic, let's say, or the father, or that they have had multiple abortions over whenever they were tried to conceive. So then the doctor will say, okay, then there is some problem here. You may have a Robertsonian translocation, you may be a carrier to some condition, and so the baby is not developing full. And let us go through the carrier status. Of course, if the mother has been see, if they are in a normal economic strata and still they are anemic for years at end, then of course they know that there is some. Again, they will take the pedigree. So the pedigree always gives you the a point where someone has got some kind of condition, and it gives away both the father's and the mother's pedigree in detail are taken, so that a carrier status could be decided. And then it's a very small screening test of blood that they will do, and they will whether the baby is the mother is or the father is a carrier, and whether the baby has chances to skip the generation or have the condition.
Is it possible to diagnose disease such as diabetes, cancer through prenatal genetic testing?
So nowadays, the high throughput high throughput sequencing methods, they do have specific genes, okay, in their panel, and this panel decides whether there could be obesity, there could be diabetes, there could be a specific type of inherited cancers. Not all cancers, most of the cancers could be sporadic. Some could be because of the lifestyle. Everything cannot be detected, but yes, schizophrenia, Alzheimer's, yes, they can detect. So there is a panel of genes, and nowadays, yes, we use that panel, and that does tell us whether a particular in future this particular baby can develop or not develop condition.
One last question we have, ma'am. What is cfDNA screening?
screening. It is cell-free DNA screening. Again, I told you here. See, when we talk about amniocentesis, or when we talk about chorionic villus sampling, or umbilical cord blood sampling, we are talking about invasive technique. Here is the cell-free technique. Cell-free technique is where I take the mother's blood. Okay, now the baby releases. See, there is a constant interaction between the mother and the baby through the placenta. So, just like the nutrients enter the placenta, or mother's blood starts heads in the placenta, through the placenta to the baby. The baby DNA fragments that are floating in the amniotic, etc., they come from the placenta into the mother's blood. So nowadays we know that this interaction happens. So we take the mother's blood. We use specific library or marker libraries where we can pull out the baby's DNA, and from this little amount of baby's DNA we can do different tests. So this is DNA, cell-free DNA testing. It's a non-invasive
Hello.
method of testing everything. Yeah.
Hello. Ma'am, I also have one question. Wanted to ask about vitiligo. That vitiligo can be tested through this genetic testing method, and what would be the probable diagnostic methods as per the genetic testing method for vitiligo?
So for vitiligo, see, nowadays what the laboratories are doing is, especially diagnostics, high-throughput diagnostic lab. If you say that I want to do this test, then they know that these are the genes involved in this condition that could be polygenic or monogenic. So if they understand that, then they make a customized chip out of it, or a customized test for you, and they will do the test for you. But that would be, of course, upon, if you say that I want this particular thing tested, then only they'll do it. Vitiligo is not being tested routinely.
Okay. Thank you so much, ma'am.
Pleasure.
I hope all the questions have been answered. We'll move to the next session then.
Sure. Thank
Now-
you very much. Thank you.
Thank you so much, ma'am. Now I take the opportunity to introduce the second speaker of the day, Ms. Adrija Mishra. Ma'am has worked as genetic counselor at Fortis Hospital, Delhi. Ma'am has also worked as senior genetic counselor and genome analyst at Bion Ventures Private Limited, Bangalore, and Lifecell International Private Limited, Delhi. Currently, she is a member of Lifeline Foundation and Befriender Worldwide, Kolkata, which lends a platform that allows scholars who are depressed, distressed, or suicidal to talk freely, and mentors to discuss difficulties, and also provide referrals while addressing their calls. She is also working as manager product genetics Indus Health Plus Pune, where she organizes training sessions for non-genetic staff and handles pre and post test counseling in a telehealth setup. Today, ma'am will be sharing light on legal and ethical issues in genetic counseling. Ma'am, it's a great honor to have you as a resource person for today's webinar. Over to you, ma'am.
Thank you. Thank you very much for the introduction. So, first of all, I would like to, congratulate everyone for choosing such an important topic, which is, the need of the hour right now. And back, 5 or 6 years back, when I decided to pursue genetic counseling as a career, there was a lot of ambiguity, and kind of people discouraged me that, is there a career after you've completed your genetic engineering from SRM. It was pretty hazy at that point. But today, after I completed my studies in genetic engineering, pursued my post graduation in human genetics from University of Cincinnati, US, and after working with so many companies who have already they have marked their presence in Indian market, I feel this is very fulfilling, and the kind of job which we do as genetic counselor holds a lot of importance. Now, today's discussion is about the ethical and legal issue that we face in genetic counseling. So, I'll start the discussion majorly, putting importance on what genetic counseling is, who are genetic counselors, the know-how of genetics, and then I'll take you towards the ethical and the legal importance. Okay, so I'll be sharing my screen. Do let me know if it is visible. Okay, so I believe, to understand any topic, it is very important to revise the basic. So I want all of you to go back to the, 8th standard basic biology textbook, where we have all read about the basic unit of heredity, which is the gene. Now we have billions of cells in human body, and each cell, have a designated organelle called nucleus. And inside the nucleus, you can see there is this, the genetic material is stored. And in the gene, there is a specific location in the chromosome, which is made up of the nucleotides. Now, these nucleotides, if you can see, the structure is majorly a double helical, okay? And it is majorly made up of ATGC, okay? Now, why am I talking about the basic of gene? Why was it like, is it necessary to understand? Yes, it is, because it's very important to know when you visit a genetic counselor and what role a genetic counselor plays. So for this, it is important to know when there is a problem with the gene. Now, coming to problem, what do we understand by problem? There is some kind of change or a variation or alteration in the gene, which in the scientific domain, we call it mutation. Taking a very simple analogy, you can think of a cookbook, right? In a cookbook, we have specific instructions given to make a recipe. Similarly, our DNA, they have a very specific code which makes protein. Now, protein is the end product, right? And we all know protein is the building block of everything. And it has very important function to, to provide in our body. Like all the building block is made up of protein. Now, when there is a mutation, it can be point mutation, it can be substitution, it can be frame shift. So just to highlight a very simple example, I have highlighted over here. You can see there is a nucleotide sequence given, CTGGAG. When there is a change of A to G, over here, a very catastrophic disease happens, which is called sickle cell anemia, which results due to a point mutation. Okay, so after this, let me tell you guys that what is genetic counseling all about? Now, there's a lot of myth and confusion which is still there in the market, that what is the actual work of a genetic counselor, or what is genetic counseling basically. Now, people do tell me that, are you doing therapy sessions, or are you just simply reading out results? No. So genetic counseling is a process of communication in healthcare, where a specially trained profession meet all the individuals or couple or family who are affected with a genetic disorder, who is at risk of maybe passing down a inherited disorder. So genetic counseling basically happens in two ways. First is the pre-test counseling, and second is the post-test counseling. Now, the genetic counselor will collect all the personal and family medical history. We take the pedigree of the person who has come to visit us, analyze and record all the phenotype, which is the physical feature of the proband, if it is available. Then we draw the differential diagnosis. We do the risk analysis. We calculate the risk, pass it down to the family that what exactly is the condition, and then we decide on the right test that needs to be done. So all of the process is part of the pre-test counseling. After we decide on the test that needs to be done, we order the test, and when the test report comes out, we help the client understand the test report in a jargon free manner. That's very important, because they are layman, right? They will not be knowing all the scientific terminologies like the inheritance pattern, the zygosity, what the condition is about. All of that is taken care, and we decode that during the post-test counseling. Again, one of the very important role that a genetic counselor has to play is provide emotional support. So when you are disclosing the result, maybe it is a pathogenic result or a likely pathogenic result to the patient, it is life changing for them. Okay? It's very difficult for a patient to undergo that emotional turmoil. So you have to provide the psychosocial support. So that is also one of the very important role of a genetic counselor. Now, who are basically genetic counselor? This is a new profession, but right now, with the extensive companies that have come up, startups, and the growing need of genetic counselors in the market, it is not so new. And currently, genetic counselors are professionals who have advanced training in human genetics and counseling methodologies. And they are part of the multidisciplinary team. We work with the lab team, geneticists, and doctors. So we also act as advocate for the patient, discuss the benefit, limitation, and the implication of the genetic testing. And the most important part is we help the individual or the client, to make them feel that they are heard, they are empowered, and we give unbiased information in a non-directive manner. What are the areas, or you may say, what are the indication for genetic counseling? So anybody and everybody cannot come to a genetic counselor. So these are the areas where a genetic counselor specifically works. So firstly, in the prenatal setting. So if a patient wants to know in depth about the option of screening test or diagnostic test, whether there is any indication that needs to be taken care, we can be of help again. And we lay out all the options, keeping in mind the ACOG guideline, the updated guidelines. And again, even before you're planning pregnancy, one can visit to understand whether the couple has any risk for passing down an autosomal recessive disorder. In that case, we can suggest the couple for carrier screening. Okay, expanded carrier screening is available, where we come to know whether the couple also carries the mutation or not. Okay, and based on that, they can actually go for a number of options, like already discussed by Dr. Trupti. We can recommend normal pregnancy with prenatal testing through CVS or amniocentesis, or we can also give them the PGT options, pre-implantation genetic testing. So these are the options that we can discuss with the patient. Other areas where a genetic counselor can be of great help is, for example, in the neonatal period, we see a lot of, patients with facial dysmorphism, birth defect. There's abnormal newborn screening test where we take a dry blood sample from a heel prick. There's global developmental delay, hearing impairment. So all of this, we need to get a diagnosis. We need to understand there is a genetic basis of all of this. Next, we can see children who are affected with several conditions like motor delay, intellectual disability, uh, autistic spectrum disorders. So all of this needs a genetic counselor, and they can come to understand and get the right test at the right time. Right now in India, we do have specialty clinic with the big hospitals which are there in the tier 1 cities. They have particular specialty clinic for cardiovascular, neurology, psychiatric, and cancer clinic. And we are trying our level best to hold several CMEs, webinars, and seminars to educate and increase the mass awareness to make the medical fraternity or the healthcare fraternity know the need of genetic counselors. The last point would be the personalized or the predictive genetic testing. This is also growing at an alarming rate right now in India, and people right now, they're realizing the importance of it. Now, just to quote an example, we all know Chris Hemsworth, right? Few days back, he did a predictive testing, and he came to know he has a high risk for developing Alzheimer's disease. Now, personalized genetic testing is a direct to consumer testing where you will come to know your genetic risk of developing a late onset disorder or a multifactorial disorder. For example, if you want to know you have a genetic risk or tendency or likelihood of developing CAD, which is a coronary artery disease, right? So there is no specific gene that will cause CAD. For this, we need to take a predictive genetic test. There are a few companies who are doing. Right now, I am associated with Indus Health Plus in India. They're pioneer in the predictive genetic testing. Worldwide market, if you ask me, there is 23andMe and several others who are working in this sphere. And I mean, people, right now, they are aware of their health, and knowing the genetic risk will help you to prevent the onset and delay the onset. So, if we tweak our lifestyle, and if we know that we fall in the high risk category of developing a multifactorial disease, we will take a customized approach, a personalized approach, and be more aware of our own health. Okay. Now, I will be speaking about the ethical part of genetic counseling and the issues that we face. Now, if you ask me about what is the need of ethics, why do we need to follow ethical code of conduct? Now, ethics is nothing but the choices that we take, and it is a system of principle or moral values that we follow to segregate the right from the wrong or good from the bad, right? Now, imagine an university or a house which is devoid of ethics. Will we be able to function? No, right? We cannot. Because ethics is something which is very, very important, and it helps in mitigating conflicts that we have. It helps us, to get an answer from the ethical dilemma in several interdisciplinary domain. For example, I will be talking today about the healthcare. So not only healthcare, we need ethics in educational institutes, in several other domain, in business, in banking, in etc. So bioethics is something which is of paramount importance, and while you will be getting your education in genetic counseling, So this is one of the very important course that each one of us needs to go through and understand the importance of it. Okay. Uh, I'll talk about the ethical principle or the pillars that we need to know before practice, before incorporating ethics in our profession. These are the four pillars, which is uh, autonomy, beneficence, non-maleficence, and justice. Now, whenever you are in a clinic, okay, you are seeing a patient, you are doing a pre-test counseling, and you are suggesting a test, for example, you have to keep in mind this word, which is very important, is informed consent. Now, it is right of a patient for getting the correct information, which is unbiased. And he has to or she has to know or ask question before, signing an agreement or signing any consent paper. So we have to respect an individual's choice and give them their own right. Next is confidentiality, which is again a very, very important aspect of ethics, which we practice in genetic counseling. And whatever, I'm sorry, whatever, data which we have or whatever report findings which we get in the post-test counseling, we cannot share it with anybody. So over here, we have to respect the client's or the patient's autonomy. Beneficence. Uh, Before taking up a profession as a genetic counselor, there should be an urge to do good. There should be an act of kindness, and you should be always in a forefront to defend the right of the client who has come to seek help from you. Non-maleficence is obligation not to harm other. If you know a result, if you know that disclosing this report result will help them. Okay? If you know a person who have had myocardial infarction or stroke, you have to give that patient, you have to write that aspirin is something which you need to take. And if you're not writing that, you are practicing maleficence, you are trying to harm that person. So that is not allowed. Next is justice. Over here you have to make sure that irrespective of religion, caste or creed, or socioeconomic strata, wherever they're coming from, you have to give them equal right and equal resources. Okay, you shouldn't be practicing discrimination. Okay, now coming to the need again of legal and ethical guideline. As I just quoted in the earlier slide, that it is of utmost importance to protect the identity of any patient, whosoever they are, and practice privacy of data. So, can you just think of a scenario where we are sharing the data of a patient with anybody, and we are chatting about their result with anybody? So what will happen exactly? Can we think of that domain? Now, if, for example, if a person's child is affected with Duchenne muscular dystrophy, and we are not maintaining the privacy code or the confidentiality, and we have just called uh, their somebody from their home or their relative, and they came to know about the result. So what will happen is there will be there can be a scenario where the person will be he'll be stigmatized, or there will be family discord that can happen, which is again very painful. So we need to make sure that we are very vigilant and we practice the code of conduct. So here I have a case for you all to understand. So this is a patient, Anita. She is 34 years old, and her sister Beena. So both of them, they came to me to discuss the test findings and which test needs to be done and the entire process. So this is just a snippet of it. Now, Anita, she presented with a medical history of colectomy. Colectomy, in a simpler way, is a surgery to remove a part or the entire part of the colon, because she was having extensive polyposis, which is severe growth of tissues in the colon. Now, we were already suspecting there were doctors involved. I was there for the case, and this is a booked case. So after we did a genetic test for her, we have found out pathogenic APC mutation, which causes autosomal dominant FAP, which is familial adenomatous polyposis. Now, we took a detailed family history for this case, and we know that her father died of colon cancer at the age of 48 years. Okay, now the next part is, in the next visit, Beena comes and what do you think? Should we go ahead and reveal the information about the APC variant to her sister? There are two scenarios to this. Firstly, before revealing any information, we have to make sure that we have a consent from the person who got tested, which is the proband. So proband over here is Anita. If Anita gives her consent that we can share the genetic data or the result with her sister, then only we can go ahead and tell her the result, or else we cannot. Okay, and this is a legal obligation, we cannot. So what do we tell her then? So in the next visit, when Beena comes to see a genetic counselor, we can only discuss the implication of genetic test and tell her the family history. So this is very simple example just to make you all aware how do we protect the information and how do we practice confidentiality. Next is the common ethical issues that we face in genetic counseling. So as I said, genetic counseling is a huge diverse field where we have several specialized clinics and several departments where the counselor works, or maybe a counselor is handling all the department. So it varies. Now, I'll talk about the usual issues that we face. Firstly, which is quite evident in the Indian scenario, is the prenatal genetic clinic, or anybody who is coming for prenatal testing or screening. Now, what happens is, at all the level, we don't have such extensive pre-test and post-test counseling. Now, which is the biggest pitfall, right? Now, people do have over expectation from a test. For an example, if a couple, they have had the first child is autistic, and in the next pregnancy, in the Gravida 2, she wants to go ahead and do a prenatal diagnosis. Now, where is the problem over here? Along with the routine screening test, which Dr. Trupti just mentioned, like the dual marker, the triple marker, quad marker, NIPT, we can do all of this. There's no problem. But going forward with a prenatal diagnosis, according to the PCPNDT Act, which we have in India, we just cannot simply recommend a prenatal diagnosis. Okay, at 16th week, let's go ahead and do amniocentesis. We cannot. Okay, so what do we do? Now, the patient, they think that, okay, my child is affected with autism. My next pregnancy, I'll get a genetic test done. So where is the ethical dilemma right now? So we have to make them understand that before proceeding with any test, first of all, we always test the index child. The index child is the first child. Now, autism being a multifactorial disease, we do have a specific panel where we have mapped gene which causes ASD. Okay, because again, it is a very complex, heterogeneous disorder. We most of the times we do not find a particular genetic cause. Okay. Now, in this case, we have to make them understand that this is a multifactorial disorder. Not necessary that always, all the time, you will have a gene associated with it. Luckily, if we test the child and we get a pathogenic or likely pathogenic finding in a particular gene or a mutation, then and only then we can go ahead and do the prenatal diagnosis in the second pregnancy. If we do not find any finding, okay, we have recommended Fragile X testing, we have recommended chromosomal microarray 750K, and we have also recommended a small panel, for example, a clinical exome for the first child, and we do not detect any mutation. In that case, we have to make sure we counsel the patient in such a way to make them understand that it is not possible. There are certain limitations for every test. So this is just one example which I could quote from the prenatal setting. So there are other issues that we come across, and in the next slides I'll be going deep into the prenatal scenario, whatever we face. Next is a lack of treatment. Now, mostly, if I talk about inherited disorders, I mean, the scientists and the research fraternity, they are working extensively day and night to find other clinical trials that are going on for gene therapy. But, by and large, if I see the bigger picture, right now we don't have treatment. There's no cure. So what we work on is majorly the preventive approach. Okay. So this needs to be, again, told in a non-directive manner to the client. Third is the false result. Now, this again is something which we tend to ignore, but again, this is of very high importance. False positive and false negative is something which should always be covered in a pre-test counseling. For example, if you are recommending NIPS, that is non-invasive prenatal screening, again, I make sure there are many counselors in India who prefer taking NIPT. You can use both NIPT or NIPS, means the same. But even doctors or patient, they have a misconception. They take it as a diagnostic test because you're pronouncing the test T. So I prefer taking the name as NIPS, which is non-invasive prenatal screening. So usually what we say is we always give them the basic description of the test, what kind of result you will be expecting. If positive, then you need to go for, excuse me, a diagnostic test, which can be a CVS or amniocentesis. But we never talk about the chances of false positive or false negative. We need to. We should be, aware enough that we talk about the false positive, again, which can happen due to, mosaicism, right? It can happen due to, for example, the mother is affected with cancer, placental mosaicism, cancer. These are the general reasons. Also, we may get false, negative result in case of there is lack of fetal tissues. So all of this needs to be laid out in a very simple manner so that the patient is prepared mentally and they can take a informed consent on whatever test they are going ahead with. Because again, they are paying for the test. It is their right. Again, I'll stress on the very first pillar of ethical principle, which is autonomy. Fourth point is again inappropriate testing. Many times we see, due to lack of knowledge, to lack of practice or awareness, I mean, there are people who go ahead with the wrong test, which is not needed at that point of time. Privacy of genetic information, we cannot go ahead and discuss it with anybody and everybody in the clinic, not even with our colleague, or with different stakeholders in the company, which is wrong. And the last point is, we are nobody to give our opinion to the patient, because in genetic counseling, the core of genetic counseling is non-directive approach. This is of huge importance. And genetic counseling is not a counseling where you prescribe or give your treatment or medicine or test. You need to have that open space. You need to allow the patient to observe and understand, weigh the risk benefit ratio, and then the onus is on them to take the call. So that is what non-directive approach is in a very simple language. Okay, because I have highlighted prenatal testing in the previous slide, and most of the ethical issues we face in the prenatal scenario. So I thought of writing or presenting the ethical guideline that we follow for prenatal testing. So prenatal testing, equitable distribution of testing should be there, because again, India is a diverse land where there are people coming from several strata, and everybody should be getting equal opportunity of testing. The one who is at high risk, maybe a high risk patient, or somebody who is primi gravida, who is pregnant for the first time. So there shouldn't be any discrimination based on high risk or a normal patient. You should be discussing the option in a very liquid, in a very open space. Every test, no matter it is screening, no matter it is diagnostic, should be accompanied by a pre-test and a post-test counseling. Because again, talking from a very practical perspective and context, a doctor or a gynae, they have a large amount of patient to see in the OPD. And these informations or these, know-how, it takes a lot of time to convey to the patient, and it should be done in a very unhurried way. So for this, I believe before going ahead with any test, a person should know what is the problematic zone, what are the gray zones, what are the limitations that are associated. And this is completely done in the pre-test and the post-test session. Informed consent is very important, and for any prenatal test which is to be done in India, we have to make sure we are providing the Form G. Form G is something which every patient should be getting, no matter whichever clinic they're visiting or whichever lab they're getting a test done from. Okay, now if the lady, there is indication for genetic diagnosis. Now, when I talk about indication, it can be a high risk for T21, 13, 18, sex chromosome, or anything in the NIPT or NIPS, or it can be in the dual marker, triple marker, or quad marker. Now, for these are the indications for which we qualify a patient for prenatal diagnosis, which can be amniocentesis or CVS. Now, there are patients in a day-to-day scenario where we see that they take all the decision based on the screening test. Now, that is wrong. That is not only wrong, it's detrimental for the couple. Okay, so even if your screening test has come out negative, to be very precise, you should always discuss the rate of false negative and false positive, and then You have to balance out the risk factors, check the maternal age, risk of preeclampsia, gestational diabetes, family history. So all of that, any tendency of consuming alcohol, is she smoking, is she on any anti-epileptic drug, because there are so many things that you need to balance, and then only you should be qualifying that patient for a prenatal diagnosis. And this should be done regardless of the couple's view. So after you give all the information, then you have to make sure you are giving a proper summary of recommendation, and this should be signed by the genetic counselor and the geneticist. Okay, many times we find in the rural India as well as in the tier 1 cities where patient try to detect the gender of the baby. Again, this is illegal, and we cannot do it in the OBG clinic. There are instances where we do reveal the gender of the baby. For example, there is sex related abnormality. So in that case, we can do with a proper documentation and proper guideline that needs to be followed. Many a times we see patient, out of curiosity, out of stress or anxiety, they will come and they'll ask for, okay, I need to, get my prenatal diagnosis done. Why can't I just, have a chromosomal microarray and a whole exome on my fetus? We cannot do that. That is illegal. Okay, that is wrong. Every relevant finding should be disclosed to the couple. So there are many, scenarios where we find VUS, variant of uncertain significance. So this is one of my favorite topic personally, where it's difficult to counsel and to come to terms on a VUS finding in a genetic report. It can be a chromosomal microarray where we find VOUS finding, or it can be clinical exome or a whole exome. So how do we handle, if we get a likely pathogenic or pathogenic finding? In that case, we are quite, we are confirmatory on the result, and we can take an proper action. We can take an action based on the pathogenic or likely pathogenic finding. The couple can decide whether they want to go ahead with the gestation, or they want to terminate the baby. But in case of VOUS or VUS finding, it is difficult because due to the lack of scientific literature or evidence, right now, according to the ACMG guideline, we are not able to classify it. And until and unless uh, we are able to classify the variant or the copy number variation into a pathogenic or a likely pathogenic one, we cannot terminate the baby before 24 weeks of gestation. Okay, so this is another classical ethical dilemma which we face. But this has already been discussed, like confidentiality is something which is of utmost importance, and we should always respect the couple's choice in case of an affected fetus. So for example, if we do a prenatal diagnosis, we do an amniocentesis, and we come to know that the fetus is affected with maybe any genetic disorder which is debilitating, which is catastrophic. In that case, it is the patient's choice. And also we give importance to the lady's choice, the mother's choice over here. So this is how we handle the entire picture of a prenatal setting along with a clinical geneticist or a fetal medicine expert. Next is a case study which I wanted all of you to see, where I can, give you a practical scenario of a patient whom we have counseled, and then we did the NIPS, and then we also did amniocentesis, and how the report looks like. All of that will be in the next slides. So this is a case where Mr. and Mrs. Sharma, they came to the fetal medicine OPD, and the time when Mrs. Sharma came, she was at 15-week gestation. So they are coming from a tier 2 place where again, in India it's difficult. All the places, they don't have proper specialized clinic. So they came to visit us in a tier 1 city. Almost she entered the second trimester, which you all can see, which is 15-week gestational age. And when I probed the patient, to my surprise, they didn't undergo any screening, no dual marker done, beta HCG of PAPE, as I guess you remember, but I'm trying to use easy terms for all of you to understand. And there was no, NT&B scan as well done at the 12th week of gestation. Now, this becomes very critical at this moment. And the lady was in an advanced maternal age, around 37 years old. Now, what options do we have right now? They have come to visit us. They have come to see the fetal medicine expert and the genetic counselor in a hospital setup. What can we offer them? And we have to, make sure that whatever we recommend or whatever we give them as an option, this should be very practical, keeping in mind all the ethical code of conduct which we have. So the best option which we could give is of cell-free DNA testing, right? So cell-free DNA testing can be done anytime after 10 weeks of gestation age to get a proper fetal fraction. Why cell-free DNA? Many of you can ask, why are you not giving them quad marker? Why are you not giving them dual marker, triple marker? Because NIPS has a very, very high specificity and accuracy, okay, which is of 99%, and it is shown to give a good result in case of singleton pregnancy. This is a singleton pregnancy. She is not carrying any twin babies. Okay, so we go ahead with the NIPS. And in the next slide, I'll show you how basically NIPS looks like. So again, NIPS, there are different type of NIPS. This is a basic one. We also have comprehensive NIPS where they cover all other chromosomes as well. So the result, you can see that she is having a high risk, okay? And when the result comes out, we again do the counseling, whatever is required, and we prepare her for a diagnostic test, because this is not confirmatory. There's again a chance of false positive that is there. So to rule this out, again, you cannot take a decision, or you cannot take any irreversible decision based on a screening test. And this is a screening test, though the specificity is very high, which is 99%. So in this case, again, because she has entered 15 week, and by the time the NIPT results came out, she was already, she entered the 16th week. And we have had a very detailed discussion about the procedural risk that is there in amniocentesis. And amniocentesis can be done after 16th week of gestation age. So there's very, very nominal, less than 1% risk that is there in the procedure, which is amniocentesis, where the fluid is extracted and we check the fetal DNA for a confirmatory result. So what test do we recommend for getting a confirmatory result? Because amniocentesis is a procedure. This is not a test. The many people, many students, many professional, they have have a notion that, okay, we are doing a test which is amniocentesis. But no, amniocentesis is the name of the procedure. The test which we do is karyotype. So in karyotype, we have come to know that the fetus is affected with T21, which is Down syndrome. So over here, you can see there is one extra chromosome, which is there at 21. So because this is a prenatal sample, we can see there is no X and Y chromosome given, because we do not reveal the gender of the baby in a prenatal case. Very, very important. So based on this, the couple can now take a call on the pregnancy. They want to go ahead or they want to terminate it, and this should be done before 24 weeks of gestation. That is the window which we have in India. We cannot go beyond it. This is again very important. And if you ask me from an ethical point of view, that okay, the fetus is already affected with Down syndrome, so this is very quite evident, right? Why will a parents want to go ahead with a child who is affected with the Down syndrome? So again, this call will be completely theirs. We are nobody to manipulate or force our advice on the patient. So at this moment, if you can just imagine, closing your eyes, that it must be so difficult for the patient to know and to absorb this news. So in this case, we have to provide you have to provide them emotional support, which is again very important in a prenatal case where the fetus is affected. Knowing about the knowing about the prognosis of the disorder, the management options, there are many. Child, even after knowing that the in utero the child is affected with Down syndrome, but there are parents who thinks that no, it's okay, it is fine, we will go ahead and bring up a child who is affected with Down syndrome. So yes, there are cases, and we completely believe in patient autonomy and patient's choice to either terminate or go ahead with the pregnancy. Okay, so I wanted to share a good news, and I am delighted or maybe over thrilled about this. So in the recent budget, we have seen our Honorable Finance Minister, Nirmala Sitharaman ma'am, she announced, and they've already launched a mission to eliminate sickle cell anemia by 2047. Now, this is a huge milestone, okay? Because I come from a fraternity where we are working day and night. More than anything, we are passionate about what we do, and we realize the importance. So in India, as a developing nation, realizing the need, okay, closing the gap, and awareness over here plays a huge importance to eradicate or to eliminate a serious disorder like sickle cell anemia. And the government, you know, uh, taking initiative is a huge success in our field. And this basically will uh, cover all the small details which requires to acknowledge the mission. This will entail awareness creation, universal screening of 7 crore people in the age group of 0 to 40 years in the affected tribal areas. Again, tribal areas, rural areas, they don't even get the basic opportunities and the basic, facilities. And again, over here, you can see counseling is of, again, huge importance through collaborative effort. of the central ministries and the government and state government ones. So yeah, this gives me immense joy to, I mean, most of you must be knowing this, but again, I wanted to touch base on this and make all of you realize that genetic counseling is no more a hazy department. We have a very promising future. You know, you can pursue it, and if you want to live for a cause, if you want to help the rare, if you want to care for the rare, I guess nothing like this. And uh, I mean, this is fulfilling in its own way. And with this, I conclude my presentation. Thank you all for, you know, patient listening. Thank you.
Thank you so much, ma'am, for making us aware about the legal and ethical guidelines. And now again, I would request our participants, if they want to ask any questions to ma'am, they can put the questions in the chat box.
We have the first question. How Klinefelter syndrome and Turner syndrome can be tested by genetic testing? Is there any treatment?
Okay, so thank you for the question. So Klinefelter and Turner, so these are tested through, first of all, you can go ahead with NIPS, okay, as a screening test. And if that comes out, I mean, a high risk, you can get a good fetal anomaly scan in your second trimester. Knowing the soft markers, the doctor and the genetic counselor can qualify you for a diagnostic test. The basic one can be done over here. You can do a karyotype and get a, you know, confirmatory call. Right now, we don't have any treatment, unfortunately. So yeah, so I mean, knowing about the result, you can go ahead and do a karyotype.
Thank you, ma'am. The next question is there any master's course available in genetic counseling in India?
Yes, we do have a master's course with Kasturba Medical College. They are specializing in 2 years course, which is already there. Yeah.
Next question is how cancer can be diagnosed by genetic diagnosis and what is the role of genetic counseling?
Sorry, come again. What is the rule of?
How cancer can be diagnosed by genetic diagnostics and what is the role of genetic counselor?
Okay, so again, I mean, right now there are specialty clinic who we have. I mean, Tata Memorial in Bombay who specialize in cancer. There are many labs in Hyderabad, but again, it is not available in all the cities. So, talking about genetic testing or diagnosis for cancer, uh, there are targeted panel which is available for germline testing as well as for somatic testing. But again, I mean, knowing the risk and benefit and the pre-test and the post-test counseling that needs to be done to find out the proper family history of the person, the course of the disease, other, you know, MRI that needs to be seen, ultrasound that needs to be seen, the medical records, all of that needs to be seen, and then a counselor will help you understand what kind of test or the right test that needs to be done. And post the test result that comes out, we give the post test counseling to the patient, and then, you know, that is how cancer patient can benefit with genetic counseling.
Is there any other questions from the participants? Thank you so much, ma'am. As there are no questions, we now move on to the validatory function. I, Mrs. Rohini Shetty, on behalf of Patkar-Varde College and the entire faculty from Department of Microbiology and Biotechnology, feels privileged to propose the vote of thanks. First of all, I would like to thank our principal, Dr. Pratibha Gayatwan ma'am, for gracing the national webinar on Biofacet genetic counseling. Thank you, ma'am, for the interesting and thought-provoking speech, which gave a beautiful opening to this webinar. I would extend a very hearty vote of thanks to both the speakers for taking out their precious time for enlightening students and making this webinar a great success. I would take this opportunity to thank Dr. Trupti Patel for her efforts towards importance of prenatal genetic testing, and would also like to acknowledge my gratitude to Ms. Adrija Mishra for her enormous efforts towards legal and ethical issues in genetic counseling. I would like to express our profound gratitude to our CEO, Dr. Mala Karkar ma'am, Chief Coordinator and Coordinator, Mrs. Ruchita Darvi ma'am, for their moral support and guidance. We are also grateful to our sponsoring organization, RUSA. This event wouldn't have been successful without the constant support from our staff members and wouldn't have run smoothly without the technical team. Last but not the least, thanking the wonderful participants who have turned up in such great number from all over the country and for their active participation throughout the webinar. Once again, thanks to all for their cordial cooperation. I will now hand over the session to Priyanka Mishra. Thank you.
Feedback link has been posted into the chat box. It's a request to all the participants to fill the feedback form, and the e-certificates will be mailed to the participants within 2 to 3 working days. The feedback link will be open for 30 minutes, so please kindly fill the feedback form.